All right. Good afternoon, everyone. It's 1 o'clock, so we have a lot to get through today. I'd like to thank you all for coming to this very exciting session on state-of-the-art immunotherapy, purpose, resistance, and toxicity. So today we have 4 short talks. There will be time for questions afterwards. There are 3 microphones in the room. If you come up to the microphone and introduce yourself, that would be great. And there are also, you could also put questions on the Q&A as well. I'd like to thank my invited guests currently on the stage. So while everyone's coming in, I might as well get going. Okay, so my first talk today is a clinical overview generally of immunotherapy in 2023. Okay, so let's go. These are my disclosures. All right, so early stage triple negative breast cancer, as everyone knows, has been the first to get approval for immunotherapy in the breast cancer space, and there's good reason for this. Of all subtypes, it has the highest level of immune infiltration. We've looked at this TIL quite extensively, and actually in all breast cancer subtypes that have TIL infiltrate, generally this is a T-cell predominant infiltrate, and the highest checkpoints in the TIL is PD-1 and CTLA-4. And this is across all breast cancer subtypes. And we know that quantity of immune infiltration is prognostic, particularly in triple negative and HER2 positive breast cancer. It's actually adversely prognostic in hormone receptor positive breast cancer. But in HER2 and TNBC, we've always worked on the hypothesis that by increasing the immune infiltrate or increasing immune response will alter prognosis of some of these tumours. So 10 years later, and we do have approvals now for both early and late stage TNBC. So this is a summary of the phase 2-3 early neoadjuvant TNBC studies that compared PD-1 agents versus placebo. Keynote 522 there on the far left was, of course, the largest study. That's the 64% PCR rate with pembrolizumab. But if you look at the Gepa-Nuevo study and the Impassion study, the PCR rates with the addition of these agents look roughly about the same. Keynote 522 had the addition of carboplatin, which resulted in a higher control arm PCR rate. But as you can see, the delta or the difference between the pembrolizumab arm and the control arm is roughly about 9%, and this is similar and in the range of the other 2 smaller studies. So the addition of these agents increases the PCR rate when added to chemotherapy. EFS is improved with the addition of neoadjuvant immunotherapy, and you can see here the curves from both the Keynote 522 and the Impassion 031 study. Oops, go back. And actually the 2-year survival are roughly the same in these studies, despite the slightly higher PCR rate with the addition of carboplatin. Okay, so let's talk about PD-L1 IHC and why there could be some differences between TNBC and some of the data I presented this morning in HR-positive disease. So here in this slide, I've tried to summarize the data with regards to PD-L1 status. So in red, and this animation is a bit annoying actually, sorry about this, going back. So in red, we have the PD-L1 positive PCR rates, which are the highest. So patients with immune-enriched tumours do the best with the addition of immunotherapy. In contrast, in grey, patients who have PD-L1 low or TIL low tumours, they do get a boost from the addition of the immunotherapy, but they don't do as well. So TIL expression or immune infiltration is prognostic in early stage TNBC, but still does not prohibit some increase in benefit with regards to PCR rate from the addition of these agents. And the way I look at this is that the quantity of the immune infiltration is important. So PD-L1 low or immune low does not necessarily mean no TIL, it just means less TIL. And the addition of these agents does cause expansion and proliferation, but clearly not enough to get that same response as the TIL high patients at diagnosis. What about early stage HR-positive disease? And you've seen these 2 studies presented this morning and during ESMO. These studies were conducted in high-risk ER-positive disease, so grade 3, and generally node-positive and stage 3. So here, immunotherapy, pembrolizumab and nivolumab was added to your standard chemotherapy, and as you can see, the results are very consistent. There is a very slight increase in the PCR rates of these two studies. And so it's nice to see that this data is consistent in the ITT population. What about in the PD-L1 positive population? So this morning we saw that in patients who are PD-L1 positive or CPS high, you get a rather larger magnitude of benefit with these addition of these agents. And you can see that here in the 7FL study, which was the addition of nivolumab using the SP142 assay. So there is a proportion of HR positive early stage breast cancers that are immunogenic, and they seem to derive quite a great deal of benefit with regards to PCR rates with the addition of these agents. So why does PD-L1 matter in HR positive disease and not in TNBC apparently? So there's been a lot said and written about the technical limitations and differences between the various PD-L1 assays, and I just highlight this as an illustration between SP142 and the 223, which is the pembrolizumab companion diagnostic. You can see there's very different staining, so potentially different pathologists would call different levels or the same levels as positive. In breast cancer, we also have heterogeneity across the primary to metastatic disease context, as well as differing immune infiltration by site of metastases. So this again can influence your PD-L1 reading in patients with advanced disease. But importantly, I think this image sums up the heterogeneity that we might encounter if we biopsy a patient, particularly with TNBC. Core 1 has 100% PD-L1 positivity, Core 2 has 0% PD-L1 positivity, and Core 3 has 8%. So there's apparently quite a lot of heterogeneity in this particular sample, and given that you take a very small core biopsy at baseline, it's quite possible that you are missing an area of PD-L1 positivity or TIL positivity. And the reason for this, I believe, is, and it has been shown, is that TNBC is heterogeneous due to its, by nature, subclonal variation, as well as genomic instability. And so you can be biopsying areas of the tumour that have a slightly different genomic makeup than another type, and that may result in either higher or lower immune infiltration. So PD-L1 low or negative in TNBC does not necessarily mean no TIL, probably just means less TIL. And we know that the more TIL you have, the better immune response that you'll get. In HR positive disease, it's likely that this is not as heterogeneous as TNBC, and likely we see a better reflection of the PD-L1 status because it's a more homogeneous clone that's expanding in the context of HR positive disease. Of course, that's yet to be proven, but I'm definitely working on that one. So EFS in the Keynote 522 is numerically improved with the addition of neoadjuvant IO, and you can see there, particularly in the PCR patients, now there is an absolute difference in improvement. Obviously, this study will never be powered to achieve statistical significance, but you can see for the PCR patients, there's around a 4% benefit in the patients who've received neoadjuvant immunotherapy versus those that did not. So it does seem now that neoadjuvant PD-1 improves the quality of the PCR that patients are getting. So getting a PCR is important, and the IO improves the quality. It does, as you can see, they improve the outcomes of patients with residual disease. I would suggest it's not all patients, but potentially patients with RCB1 and 2 are also getting a boost with the addition of immunotherapy. Does not, however, imply that the post-surgical or the post-adjuvant immunotherapy is doing anything beneficial. And I think the data this morning from the Impassion 030, which was the adjuvant atezolizumab trial, does support that. So a lot of people ask this question, and particularly in resource-poor countries. In this setting, I would personally prioritise non-cross-resistant therapy over further pembrolizumab in patients who have residual disease in the setting or after neoadjuvant immunotherapy. So this means CAPE, olaparib, or potentially in the future in HR positive disease, CDK4 inhibitors over pembrolizumab. At the moment we add, but that's because that's the best evidence we have. So evidence says, yes, we do need the post-surgical immunotherapy in case of a PCR. Obviously, there are trials ongoing with regards to that. But the science tells us that potentially the post-surgical immunotherapy is less important, and this is because we know in the setting of tumour you get better expansion and diversification of the T-cell response, and when you clear the tumour, you maintain T cell fitness. So when the tumour is removed surgically, the T cells are allowed to recover and they can remain fit to survey the body in case of recurrence. And in the future, I think we'll have better markers to help us identify these PCR patients that are cured. And these may include, for example, the baseline TIL infiltration, high equals good, TCR expansion in the peripheral blood that's maintained post-immunotherapy, and post-surgical MRD liquid biopsies. But of course, these assays have to be super sensitive in order to tell us definitively if these patients are cured. So next question, do we need all that chemotherapy? So Keynote 522, as everyone knows, is a very intensive regimen, carbotaxol followed by AC, did not include patients with lower node negative tumours. So to help answer this question, I've got some studies here, and sorry, but this animation is really driving me nuts. So these are all the studies at the moment ordered by chemotherapy duration. In blue is the ITT population, in red is the PD-L1 or TIL high population, in grey is the immune poor population. You can see that the longer duration of chemotherapy in the red, the immune high population, are getting really good PCR rates. In the next block where we have the NeoPact and the NCI study, you can see there with just 12 to 18 weeks of carbotaxane-based chemotherapy, patients with higher levels of immune infiltration are still achieving really high PCR rates. And we'll be presenting some data from the NEO-N study, which is very similar to the NCI study, which also supports that in patients that have high immune infiltration at baseline, you can achieve very high PCR rates with less chemotherapy in the setting of an immune agent. So in immune-enriched tumours, PD-1 inhibitors can have large effects. I think that's because you're allowing T cell proliferation in the setting of less myelosuppression from intensive chemotherapy. This is supported by the NeoPact data that was just recently published by Parenka Sharma et al., which shows again immune enrichment, PD-L1 positivity achieves high rates of PCR with here just 18 weeks of carbotaxane-based therapy and excellent event-free survival if you achieve a PCR. And why is chemotherapy or less chemotherapy important? This is because we know that patients with sustained lymphopenia post-adjuvant chemotherapy has adverse effects. And you can see here that using data from a single institution, women can have sustained peripheral lymphopenia at 12 months post-chemotherapy, and this is worse in premenopausal women versus post, worse in patients that have received radiotherapy, and worse in patients that have received dose-dense AC. And we know that sustained lymphopenia long-term is adversely prognostic, not only from a cancer point of view, but from also infections. And this suggests that us being able to optimize and finesse our chemotherapy may be helpful. So there are lots of other biomarkers that I'll just briefly talk about in the next few minutes. So ER expression this morning, I think there's some nice data now suggesting that patients with lower ER expression should be treated more like TNBC. In the 7FL data, this was less than 50%. The Keynote 756 data was consistent with this. You can see here the higher boost achieved with patients with lower ER expression. And similarly, patients with lower PR expression, we should probably be thinking of them like TNBC as well. As you can see there, patients with PR less than 10% are getting quite a large increase in their PCR rates with the addition of these immune agents. And the Keynote 756 data was consistent with this, and we'll wait for long-term data to hopefully support this in the EFS setting. So just some interesting things that may also influence your PCR rate. So this data was recently published. So exercise and nutrition potentially may increase your PCR rates. Why is that? Well, potentially being more active allows your T cells to circulate, and we know that athletes have quite significant thrombocytosis and neutrophilia and lymphophilia after exercise. And in the melanoma literature, stress can adversely affect your outcome in the setting of neoadjuvant therapy. So a lot of other factors related to the patient have yet to be studied and related to our immune response. And then finally, this leads us into the next talk. I'm just going to talk very briefly about treatment-related AEs and specifically related to Keynote 522. I know that you now have a lot of experience or some experience with giving patients this regimen, and it's not the easiest regimen, and I will just point out that in this study, which is a clinical trial, and we know that only the best patients get on to clinical trials, that 1 in 3 patients had an adverse event serious enough to mandate or to warrant discontinuation of any drug. So this is 1 in 3 patients. Probably in real life, this is more like 1 in 4 or 1 in, more than 1 in 3, 1 in 2.5. So please watch your patients very carefully when you're giving them this regimen. And particularly, I currently recommend patients get weekly carbotaxol due to this reason. You're getting side effects and adverse events very early on in the treatment setting. And particularly, I'll just highlight 3 adverse events: infusion reactions. So sometimes the fever can be quite difficult to manage in the setting of carbotaxol and can require quite a lot of steroids. I usually recommend to drop the carbo early on in that setting. But do also watch out for hypophysitis, as this can affect patients when they undergo their mastectomy and reconstruction if they're on permanent cortisone replacement. And also, please keep a close eye on their creatinine and their thyroid function as well. These side effects are very common. I'm quoting about 1 in 5 patients will have an adverse event related to immune dysfunction, and at the moment we cannot predict who these patients are. So in conclusion, PD-1 targeted therapies and chemotherapy is currently standard of care now in early stage triple-negative breast cancer. The data is promising in immune-enriched hormone receptor-positive breast cancer, and neoadjuvant treatment is currently standard. Patients with early-stage TNBCs who are immune-enriched, particularly those that are lower stage and node negative, I personally believe we can get away with shorter duration chemotherapy in the setting of pembrolizumab, and we can escalate or de-escalating in the setting of their surgical response. Patients with HR-positive disease, there's clearly a subset here that are immunogenic, and hopefully the longer-term data will support this. But these patients are traditionally doing quite poorly, so I think it's great that we have a therapy that can potentially change their natural history in the future. Patients with immune-poor tumours, I think we have no choice but to give the full Keynote 522 regimens, but other chemo combinations or particularly engineered T cells or CARs in the future will help us with those patients, and that leads us on to our other speakers today. PCR, it's unlikely more adjuvant pembro benefits, but we obviously have yet to have definitive data about that. And residual disease, this is the place where we need escalation. So we currently have ADCs in testing, and more understanding of the biology of these patients is needed, those that are immune poor at diagnosis, and also those that recur. Now we're giving routinely immunotherapy in the early stage setting. And finally, we know that Keynote 5.2 is associated with considerable adverse events. We don't understand who these patients might be, and that's why we have our next speaker giving a talk shortly on this very topic. So I'm just going to open that up quickly for questions before I introduce the next speaker. So if you have any questions, please come to the microphone or yell out or type on your app. Or if you have no questions, we can all move on.
Thank you for that excellent presentation.
Thank you.
Murali Biram from San Antonio. The question is it fair to extrapolate the data from Impassion 030 to pembrolizumab or nivolumab studies which haven't been conducted yet? Because not all IO agents are created equal, and the same applies to these as well.
Yeah, I mean, that's an excellent point, and obviously, I'm extrapolating. But, I think that there's other data that does suggest that the adjuvant setting is not the best place to place an immunotherapy agent. In breast cancer so far, there doesn't seem to be huge differences between the PD-1 and PD-L1 agents, and certainly the Impassion 031 and the EFS curves look quite good, even though obviously that study was not powered to see a difference. We will have data from further atezolizumab phase 3 studies in the future, so that question remains to be answered. Yes. Yes.
Hi, Alan Elder from University of Colorado. I just had a question about if any of that data on survival or adverse events was stratified based on local lymph node removal, and if you see any difference between patients that do or don't have their lymph nodes.
So the question is no, the data is not stratified by that. But yes, it's an excellent question. I mean, the question relates to, having the draining lymph node present or not. So I think we don't know the answer to that question. There are some studies looking generally at the survival of patients who have nodes removed and do not without immunotherapy, and that survival is pretty equivalent. So in the setting of immunotherapy, at the moment, we don't know how important leaving the lymph node architecture is.
Thank you.
Mark Sherman, Mayo, Florida. Since we're giving so much immunotherapy and so much prednisone for nausea and vomiting, I'm curious as to whether anyone is adjusting for that, the timing, the dose, and how people should be thinking about that. Thank you.
Yeah. So yes, this is obviously, that was an area of concern. So when the first Impassion 130 study was designed, which was in the metastatic setting, that was designed with nab-paclitaxel to try and remove the steroid question. My personal take on it at the moment is that short-term bursts of steroids are okay, as long as patients are not on steroids continuously. But steroids do cause neutrophilia, as you know, and so that could be adversely impactful, but at the moment, I think the short bursts we use for anti-nausea doesn't seem to be so impactful. Yes, Dr. Kropp.
Ian Kropp from Yale. Sherene, great talk as always. I'm interested in your hypothesis about the heterogeneity of triple-negative disease, explaining the lack of predictive ability of PD-L1 status in neoadjuvant therapy. We don't see that in the metastatic setting where PD-L1 seems to be very reproducibly predictive of benefit. Do you think the difference would just be that that's based on, many times based on primary cancers that are bigger and you can assess PD-L1 status in that case versus core biopsies? The difference just seems so clear between neoadjuvant triple negative and metastatic triple negative, neoadjuvant, ER positive. It just feels like it should be something more than just testing differences.
I mean, yes, I agree. I mean, I think the PD-L1 assay is poorly sensitive as well, so I don't think negative is really negative in the TMB setting. In the advanced setting, however, I think there's a different biology occurring. So patients that recur post-early stage have managed to evolve in the way that their tumours have evaded the immune system. So from that point, I think the clone or whatever metastasis has evolved is probably a little bit more homogeneous, and we may see a more representative example of the PD-L1 status when we biopsy it.
Thank you.
Great. Okay, so we might move on to our next speaker. So it's my great pleasure to introduce Dr. Toni Choueiri from the Dana-Farber Cancer Institute. So he's not a breast oncologist, but he's going to educate us on biomarkers related to immune-related adverse events. So thank you, Toni, for coming.
Thank you. Thank you for having me here. Thank you, Professor Loi and the organizers. I'm going to talk about biomarkers of immune checkpoint inhibitors, but for toxicity. I mean, most of the work is really based on response and resistance. These are my disclosures, especially the last line. And I don't need to tell the audience about what the immune checkpoint inhibitor now over a decade did to the field of oncology, unless you were living under a rock or in a deep, deep cave. Many approval. I stopped here to 2022, but many approval are coming. Almost every tumor is touched by an approval of an immune checkpoint inhibitor. Specific to breast cancer, one drug, pembrolizumab, approved in 2020 in first line in triple-negative metastatic breast cancer in combination with chemotherapy based on KEYNOTE-355. 1 year later in 2021, pembrolizumab, the same drug, in combination with chemotherapy approved based on KEYNOTE-522 in the neoadjuvant setting. And you have a new class of agent, you have a new class of side effects that we call immune-related adverse event. This slide that I made summarizes here the most important side effect and their timing. And the bottom line is, these are not mutually exclusive, meaning any side effect to any organ, immune-related AE, can happen. Now, of course, hypophysitis, which has been described with PD-1 inhibitor, is way more common with CTLA-4 inhibitor. Pneumonitis, way more common with PD-1 inhibitor. Most of the side effects actually happen early, within the first 3 months, but we've seen side effects on folks on immune checkpoint inhibitors years after. Again, the side effects when you use 2 immune checkpoint inhibitor may be not relevant to breast cancer, like a CTLA-4, any PD-1, are more. Well, relevant to this audience, wanted to present some of the specific immune checkpoint inhibitor toxicity. This is very elegant work from Professor Loi on my left here, as well as Carla Hutt, and looking at immune checkpoint inhibitor affecting fertility. This was published last year in Nature Cancer, clearly showing the primordial follicle after ICI exposure, going down. This is in mice, as well as the oocyte become really less healthy, more dead. And this is related to the fact that immune checkpoint inhibitor increase, no surprise, circulating cytokine. And if you look at the intra-ovarian milieu, it's full of inflammation and increased cytokine. But even more, I think this should be tested, like everything, prospectively, and this is a phase 3 trial run by Dr. Sarah Tolani, Optimize RD, that will collect information about fertility in a prospective fashion, and I would say will involve, really focus on collecting that information in a systemic way. Now, also, this is just published in the journal. This is an exposure in utero to pembrolizumab, and this is an infant that had a diarrhea that was intractable, failure to thrive, ruled out from multiple conditions. You can see here the radiologic exam, echo, ultrasound, but also the duodenoscopy and the gastroscopy. You see this red membrane, and also the histologic evaluation. This at the end up being a pembrolizumab and checkpoint inhibitor induce immune-related AE affecting the GI tract. Patient responded to infliximab. Patient responded also to steroids. So this could happen, and you should keep that in mind, relevant to this audience. How do we manage this? And every society almost that deal with oncology do have their management paradigm. I picked here from a couple of years ago, and they're updated online from ASCO and from SITC. But the bottom line, it depends on the grade of toxicity and the organ involved. I'm not going to go into details. But to tell you also that immune-related AEs is not necessarily bad. This is in lung cancer. Lung cancer has been one of the poster child for checkpoint inhibitor. Immune-related AEs have been associated, irrespective of the duration, you get the checkpoint inhibitor with an improved benefit. And in my practice, if I have a severe immune-related AEs and a patient was benefiting, I really stop the drug and I continue observing, and many of these patients do not recur. So it's not all bad. But the importance in, can we predict immune-related AEs, where like almost everything in life and in oncology, it's not simple. The mechanism involved in immune-related AEs tend to be very complex. They are poorly understood. We try to relate a lot of the study from the science that is many, many decades old of autoimmune diseases. It's not the same. In part, there's an interplay between multiple factors, all the way from clinical factors to genetic factors. And I'm going to show you examples here. I put them in tables based on the publication. Females in some studies, but not all studies, have had increased rate of immune-related AEs, certainly pre-existing autoimmune condition. That's what we base our clinical workup on. Some autoantibodies, especially thyroid autoantibodies, and less so other antibodies, have been associated with thyroid-specific immune-related events. Publication here from Zhu looked at blood parameters, also circulating cytokine, no exception, as well intestinal microbiome. almost all the data about the microbiome and modulating the microbiome and the state of the microbiome is about resistance and response to immune checkpoint inhibitor. But there is this study, a couple of studies here looking at Bacteroides intestinalis, increasing the chance of ileitis, as well as some work on genotyping with HLA. Bottom line today, no biomarker is currently used in clinical practice to predict immune-related AE. Now, this is a quite elegant work, and it's very granular. These are patient subjects that had peripheral blood for their T lymphocyte. They developed specific kind of immune-related AEs, and using the most recent platform, single-cell RNA-seq and site-seq were performed on these samples. And it shows you also in a granular way that talking about CD8, CD4 is could be a bit naive. So for example, here, specific kind of CD8 T cell, the central memory CD8 T cell, an increase of them is associated with a decreased risk of specific immune-related arthritis. On the other hand, specific kind of CD4 T cell, and there are many, once you start digging in the science of single cell and looking at that level, could be associated, Th22 and 47 here, it could be associated with pneumonitis and thyroiditis. So what we've done at Dana-Farber here, we teamed up, this is my partner, Sasha Gusev. We teamed up with folks usually way smarter and know mathematics and coding way better than myself. We have on every patient for years at the Farber ordered, even on patient with early stage disease, genotyping, NGS. We took 2,600, over 2,600 patients treated with immune checkpoint inhibitor across all tumors. This was the discovery cohort, and with my team of postdoc, we curated the immune-related AEs very well, looking at the medical record. And with this, using computational methods developed by Dr. Gusev, we can impute the SNP. Using tumor sequencing, we can go back to the germline. This 2,600 patient, we found 3 SNPs associated with immune-related events, all grade, high grade. This was published last year. We did validation in 3 cohorts on the left, upper left, and a cohort at Dana-Farber, another cohort in our close friends at MGH, and a third one, Roche, was very generous to us, very collaborative, gave us setting of 2,200 plus patients. We also validated it at Roche. And in a meeting, like this meeting, we met Ben Fairfax from Oxford, who was working also on melanoma in 214 patients, and we validated. So 1, 2, 3, 4 cohort validation for the SNP in interleukin-7. Now, you may come and say, well, this predicts toxicity, but there is something beyond immunotherapy. What about chemotherapy? I mean, what about target therapy? I treat GU, I treat kidney cancer. I use a lot of these VEGF target therapy. What about toxicity there, where we curated those 20,000 patients that had toxicity, but there is no signal that this is also specific to other systemic therapy? Breast cancer, this is a breast cancer conference. We took the 168 patients against immune checkpoint inhibitor, not common give in breast cancer like other. And again, this is a hazard ratio of near 5. The SNP effect was seen across all cancer types. Now, but that SNP effect, how common at the end of the day, if you want to take this to general practice and start ordering, how common in the general population? So we looked at the data with my postdoc, Eddie, and Sasha, and we looked actually the most, and by far, genomic data come from white European, and that SNP is only present in 8%. On the other hand, talking about diversity in clinical trial and reporting research, it's over 30% in African American normally. We had a handful of patients, or in Asian. So this is a cry of help from any one of you who has curated set of immune-related adverse event on your patient, no matter what sequencing platform you have, as long as we have access to the data, we could collaborate. Now, what's the biologic rationale? The first 2 up, the yellow or orange and the light blue, are these the carrier, homozygous, we had couple, or heterozygous? This SNP create a cryptic form, an exonic form of IL-7. It's a cryptic IL-7. You can see here IL-7 expression. And on the right, this is the work by the Fairfax lab. That's the parallel paper we had with our Oxford collaborator, showing at the single cell level, the expression is not everywhere, but also dominated by CD19. So now we understand what cells, has this high expression. Now, you may also say, well, actually, you created a problem here because, yes, that SNP predict toxicity. I'll give you that. But what if that SNP predict response? So what are you going to do? I mean, that step, great. It predicts toxicity, but we need to use it to predict response. So we had data from a renal cell study, I have to say, of systemic therapy checkmate 025. And no, it does not predict survival. So in the future, what is the next step? When you write a grant here, you always have to have the next step. Perhaps one day, in high-risk patients, certainly not just European, where it's 8%, you look at the carrier, and perhaps one day you can randomize to immune checkpoint inhibitor and immune checkpoint inhibitor plus immunosuppressive drug. Well, is that going to go against immune checkpoint inhibitor? I would say no, but let me show you before. This is a model from our colleagues in Asia where it says one side does not fit all, and the Eureka and the Holy Grail does not exist. It's multiple things. This is a beautiful predictive model using AI where looking at immune-related AEs, but not just looking unidimensional, but looking at this in terms of doing everything you can think about it, whole exome sequencing, doing GWAS, doing also the CBC count, looking at the eosinophil, and integrating everything in one model. Obviously, for this, you need thousands and thousands and thousands of patients, and that's why we need to all work together. There are still some remaining relevant questions for everyday practice. So I told you about steroids. I'm going to start really patient on PD-1 inhibitor and give them steroid at the same time. I mean, is that, well, I'm not a big believer that this is completely wrong. This is a lot prompted by this study from MSKCC and kind of validated by friends from France, where 10 milligram prednisone or higher in lung cancer was associated with a worse PFS and OS. But when our group here, led by Mark Awad Lung Cancer, looked at it and looked again, the nature of retrospective study, which we do more and more, if the steroids are taken for palliative reason, I use steroid end-of-life patient, this all the time, versus non-palliative indication, there's a difference. And if they're taken for non-palliative, actually, indication, let's say an immune-related adverse event where someone is only on first-line therapy, there is no difference on prognosis. So actually, having steroid could be the fact that you may have worse disease. Can we restart immune checkpoint inhibitor after really severe immune-related AE? This is, again, work from our postdoc, Sarah Boalawi, that went to Yale and followed Dr. Weiner here, where 50% of immune-related AE do recur, but luckily, none are 4 and 5. So make your call here if you need your checkpoint inhibitor or what. Again, a vulnerable population, okay, this is work we did with our lab with Talal Zarif and Amin Nassar, who also went from Harvard to Yale. And we showed in the largest population of patients with HIV who got immune checkpoint inhibitor that immune checkpoint inhibitor can be safe, can be effective in patients living with HIV, irrespective of the CD4 count. These are my conclusion. I believe most biomarker study of IO, I would say over 95%, were focused on biomarker of response and resistance. And in my opinion, including work from my own, this resulted in a modest, and I'm being here generous, modest return on investment. The mechanism of immune-related AE remain quite complex, and ongoing autoimmune diseases and, are the obvious biomarker today, sadly. Hopefully, germline biomarkers may be readily available and may lead to prospective testing. Thank you again for the kind invitation. I'm enjoying my time very much. Should I stay?
In the interest of time, I might get you to put your questions on the chat for Dr. Choueiri, and we might move on to the next speaker. Sorry, Tony.
Okay, that's
So our next speaker, so if you put them on the chat, Tony, I'll pass the computer and he can answer them. Our next speaker, I'm very pleased to invite Dr. Valentina Hoyos to the stage, and she'll talk a little bit about engineered T-cell therapies and what we can look forward to in breast cancer. Thank you.
Good afternoon, everyone. I'd like to thank the organizers for this very gracious invitation. Today, I will discuss the outlook for engineered T-cell therapies for breast cancer, focusing on those studies that have shown both the advancements and the limitations of this treatment. These are my disclosures. So to generate engineered T-cell therapies, the process involves taking the patient's blood, activating the T-cells in vitro, and then inserting a T-cell receptor transgene that can be either a chimeric antigen receptor or CAR, or a T-cell receptor or TCR. This receptor will redirect the T-cells towards a tumor target. The engineered T-cells are then given back to the patient where they will recognize and attack the tumor cells. In the bottom right, I have illustrated what happens normally when a T-cell gets activated by an antigen-presenting cell. Basically, the alpha and beta subunits of its T-cell receptor bind to and recognize a peptide or piece of protein that is being presented by the other cell's HLA molecule. The TCR needs the other CD3 subunits to be able to be expressed and to signal. And for full T-cell activation, it also requires a signal from a co-stimulatory molecule that can be CD28. So to generate engineered T-cell therapies, you can take the alpha and beta T-cell sequencing from T-cells that you already know recognize the peptide of interest and engineer all of the T-cells to have the same alpha-beta TCR, therefore redirecting them all to one specific peptide. On the other hand, you can also engineer T-cells through another mechanism to redirect them against cancer, and this is through a chimeric antigen receptor, or CAR. A CAR combines the specificity of a monoclonal antibody by taking the variable regions of it with the signaling of a T-cell receptor. And we know that for better efficacy in vivo, CAR structures can also incorporate other co-stimulatory molecule signaling, and this improves their activity in vivo. In this case, CD28 is an option. 4-1BB has also been used quite a bit. So now that we know this, we can know the pros and cons of choosing which one of the two options to engineer your T-cells with. First of all, CAR T-cells have a big advantage, and that's that they don't need HLA presentation to be able to recognize their target, and therefore they can be universally applicable to all patients regardless of their HLA subtype. Because a CAR doesn't need the other CD3 structures to be expressed or signal, you can also redirect other immune cells with a CAR, like NK cells or even macrophages. But CARs can only recognize molecules in the surface of the target cell, and they require usually higher antigen density. On the other hand, TCRs are able to recognize proteins in any compartment of the target cell, including the intracellular compartment, which is where the majority of the cell's proteome is. And they can recognize even very low levels of antigen expression. However, because they depend on HLA presentation, those treatments can only benefit the patients that have the specific HLA that the TCR binds to. So to have a better idea of the current status of engineered T-cell therapies for breast cancer, we looked at data from clinicaltrials.gov. And I'd like to thank Lauren and Diego from my lab for their help with this analysis. We found that the first clinical trials using engineered T-cell therapies in breast cancer patients started in 2013, and there has been overall an average of about 4 new clinical trials per year since then, with a total of 50 trials using these treatments in breast cancer patients. We can see in the table the different targets that these clinical trials include. It's not surprising that HER2 is up there, and second is MUC1, and third mesothelin. Looking at the data from these trials, we see that the majority of them are targeting a target that is overexpressed in tumor cells, but it's not exclusively expressed by tumor cells. And these are just overexpression, tumor-associated antigens. All of these trials are either phase 1 or phase 2, and almost all of them are being done at the United States or China. Regrettably, 86% of the trials have yet to report any results, which is a big bottleneck for this field. Here we have a table summarizing the results that we do have available from these trials, and these are 7 different clinical trials. Now, I don't have the time to go into them in much detail, but I will tell you the overall points here to make. And one is that the toxicities seen are not major toxicities that would limit the further development of these treatments. Also, most of these trials included very few breast cancer patients, some of them even only 1 patient. There were some good responses in some patients, but unfortunately, none of them were from the breast cancer patients, except for one trial, which I want to highlight down here. This is a trial done by Steven Rosenberg's group at the NIH. They reported treating only 1 patient with a TCR T-cell therapy that targets a mutation of TP53. And this was a very heavily pretreated ER-positive metastatic breast cancer patient that had received a total of 10 prior lines of therapy, including hormone therapies and chemotherapies. The patient received lymphodepletion before the T-cell therapy and pembrolizumab 16 days after. She did experience grade 3 acute CRS, but this resolved with treatment. And what they saw was a dramatic response in the patient's necrotic fungating breast cancer masses with complete resolution of the masses by day 60 after T-cell infusion. The biopsy of the tumor showed increase in the T-cell infiltration, decrease of the TP53, which is the target for these T-cells, and an increase of PD-L1 expression by the tumor. There was an overall 55% decrease in the tumor burden in this patient, but unfortunately she did progress 6 months after treatment, and they found that this was due to loss of the HLA expression that the TCR binds to, which in this case is HLA-A2. What about preclinical results with engineered T-cell therapies for breast cancer? These are a list of other targets that are currently being explored in preclinical breast cancer models. And finding such targets is one of the focuses in our lab. We do this in collaboration with Bing Zhan, a renowned proteogenomics expert at Baylor. This is the project of a fantastic grad student in my lab, Lauren Soames. Basically, we found that Sona pellucida is a novel target for triple-negative breast cancer. This protein is expressed only in the surface of oocytes as they're ovulated. We found by RNA sequencing and IHC staining that this expression is limited only to the ovaries and those oocytes that are being ovulated. Also looking at the RNA sequencing data of breast cancer samples in general, that's what's publicly available to us, we found that about 10% of triple-negative breast cancers express CP4, and we confirmed this in our patient-derived xenograft models. So for more information on our CP4 CAR T cells, I invite you to visit her poster on Thursday afternoon. But let's say that you do find the ideal target. CAR T cells or engineered T cells still have to overcome a lot of different barriers to be able to be very effective in breast cancer. A T cell has to extravasate from the blood vessel. It has to infiltrate a dense extracellular and stromal barrier. If it gets to extravasate and get into the tumor, it is then bombarded with a lot of negative inhibitory signaling that comes from many different cells in the tumor microenvironment, including monocytic and granulocytic MDSCs, cancer-associated fibroblasts, M2 macrophages, endothelium, and even Tregs. If it manages to stay immune to all of these inhibitory signalings, it still has to overcome the challenges of the tumor itself, including the heterogeneous expression of the target antigen, the inhibition of the tumor cells themselves by checkpoint inhibitor and other mechanisms, and as we saw in that patient I mentioned, HLA downregulation if this is a TCR T cell. So investigators in the solid tumor cell therapy space have been trying to find other alternatives to be able to further engineer the cells to overcome these barriers in the tumor microenvironment. I will focus only on the studies that have shown results in breast cancer models. The first option to increase the proliferation of T cells at the tumor site and overcoming the microenvironment is to incorporate another positive signal through a transgene of a cytokine receptor. This group from Shanghai showed in immunocompetent mouse models that EGFR targeting CAR T cells that also express IL-18 and CXCR2, which is a chemokine receptor that will lead the T cells to home towards the tumor, will increase the anti-tumor activity of the CAR T cells and lead to increased survival, as well as increased infiltration of T cells at the tumor site. Another option is to use a constitutively active form of the IL-7 receptor. This is a receptor that signals constantly without the need to be engaged with IL-7. And Dr. Diego Chamorro is a very talented MD postdoc in my lab who is trying to test the difference between this receptor and IL-15 overexpression in HER2-positive CAR T cells, in HER2 targeting CAR T cells, in a breast cancer model that has high infiltration of MDSCs. For the first time in years, using this model, we have found that some of these mice have complete responses to the treatment, and I would like to invite you, if you want to have more details on this data, to his poster on Friday afternoon. Another very interesting way to increase the activity of CAR T cells is to use what are called switch receptors, and this is very clever. It's basically taking the intracellular domain, signaling domain of a negative receptor and switching it for that of a positive receptor. So in this case, IL-4 for IL-7. So in the microenvironment, when the cells are trying to inhibit the T cells by producing IL-4, the T cells instead will get a positive signal. Bajgain et al. Showed that in MUC1 CAR targeting T cells, in a breast cancer model overexpressing IL-4, they can overcome the inhibitory effects of IL-4 and have significant improvement in their anti-tumor activity. You can also completely knock out a negative signal. For example, we know that adenosine is a very potent T cell inhibitor. This group from the University of Melbourne in Australia knocked out the receptor for adenosine on T cells, the A2AR, using CRISPR-Cas9, and found in an immunocompetent mouse model that HER2 CAR T cells improved their activity in vivo and led to a prolonged survival. In our lab, we also try to target myeloid-derived suppressor cells, because we know that these cells can inhibit T cell function by many, many different mechanisms, which are listed here, and I won't go over. But MDSCs also promote tumor growth, and in breast cancer patients, they're associated with a poor prognosis and an increase in the disease burden, as well as poor response to immunotherapies. We know that MDSCs express high levels of TRAIL receptor 2, and this is a receptor that induces apoptosis of the cell when engaged with TRAIL. So we engineered a receptor that will bind agonistically to TRAILR2, leading to apoptosis of the MDSCs, but at the same time will give a positive signal to the T cells through 4-1BB. Both HER2 and MUC1 CAR T cells showed improved activity in these breast cancer models with high MDSC infiltration when incorporating this receptor. And this led to increase in the proliferation of the T cells at the tumor site. So where do I see the future of cell therapies for breast cancer? I believe that cell therapies will show higher response rates when we incorporate these mechanisms that I have presented to you today. So trying to overcome the tumor microenvironment and improve their ability to persist in patients with solid tumors. I also think that if you incorporate these cell therapies earlier in the disease course, you're more likely to have successes, as we've also seen for other immunotherapies. And as we increase the use of omics, we will have more targets that will be discovered and explored, and we will also discover biomarkers that can predict response to treatment. And off-the-shelf therapies will become available to patients, which will definitely decrease the cost of this treatment. AI's contribution to the field will include discovery of TCRs and CARs that will give AI predictions of new TCRs, and finally, more accurate hypothesis and discovery and success. And with that, I'd like to thank everybody and the supporters of my lab. Thank you.
Thank you, Dr. Hoyos. Again, in the interest of time, if you can put your questions on the chat and she can answer them. And our final speaker today, I'd like to introduce Dr. Kevin Litchfield from the University College London. Thank you for coming, Dr. Litchfield. And he will give us a talk on his research regarding resistance to immunotherapy and chromosome instability. Thank you.
Excellent. Thanks so much, everyone. It's a great pleasure to be here. So I'm going to step into chromosome instability and its role as a driver of resistance to immunotherapy. Just my disclosures for this talk. So we've been interested for a number of years in the drivers of IO resistance. We published in 2021 a big meta-analysis of over 1,000 patients, including breast cancer and 5 other cancer types from a dozen different clinical trials. And here you can see an overview of that study, and it really helped us understand the biomarker landscape for IO response, which biomarkers are important and which ones fail to validate. And you can see, in keeping with much of the literature, we saw biomarker with strongest effect size, with tumor mutation burden, particularly clonal tumor mutation burden, so a measure of mutations in every cancer cell had the strongest effect on predicting positive outcome to treatment. We saw other interesting observations. CXCL9 expression, for example, had very strong effect size, more important than PD-L1, CD8, or any T-cell inflammation signatures. CXL9, of course, is important for driving T-cell infiltration secreted by immunostimulatory macrophages to attract CD8-positive T-cells to the tumor microenvironment and tertiary lymphoid structures. We also saw a very strong effect for CXL13. Another key cytokine in the top right there is overexpressed in both functional models as well as higher in patients that responded to immunotherapy treatment. CXL13 is well known for its role in promoting tertiary lymphoid structure formation, as well as in being a marker of tumor reactivity in CD8-positive T cells. But I think what struck us most from this work is the box in the middle, several biomarkers that despite being from the literature, despite being from high-impact papers, failed to have a consistent association with checkpoint inhibitor response. And several of these you can see here: somatic copy number alteration burden, loss of heterozygosity at the HLA locus are all classic hallmarks of chromosomally unstable tumors. And so this was really perplexing. We know chromosome instability clearly has a strong role in driving tumor evolution and driving clinical outcome. So why was there not a clear link with immune response? And our interpretation really is it comes down to the complex nature of sin. It can have both an immunostimulatory effect, but also an immunosuppressive effect. For example, in an immunostimulatory context, we have exonic fusions where 2 proteins fuse together. This can create very potent antigens that elicit a T-cell response. We know sin also activates CGAS-STING pathway that can be immunostimulatory. On the suppressive side, we know copy number loss can lead to defects in antigen presentation. Whole genome doubling in tumors can allow for deletion of parts of the genome that are immunogenic. And then generally more unstable tumors have a great ability to adapt and acquire resistance to treatment. So just going a bit more detail into each of these areas. So we were very interested in the role of exonic fusions, particularly structural variants. How do they affect immunotherapy response? And so for this, you need whole genome sequencing data, and there's been a huge shortage of checkpoint inhibitor cohorts profiled with whole genome assays. And we were fortunate to have access to a cohort of around 300 patients through the Genomics England effort that had checkpoint inhibitor treatment and the whole genome assay. You can see an overview of the cohort here, breast cancer and 5 other cancer types included. We first of all validated previously known biomarkers in this cohort, so tumor mutation burden, for example, clearly a predicted outcome, and that was a treatment-specific effect. When we did interaction term analysis with non-IO treated cohorts, we didn't see that same predictive effect. Across all biomarkers, again, we saw clonal mutation burden having the strongest overall predictive effect, followed by neoantigen count, and then coding and whole genome TMB and TIL fraction. And what was interesting when we looked at the structural variant burden, we saw, for example, breast cancer was highly enriched and highest ranked for SV burden in this cohort, at least compared to all other cancer types, higher in fact than other classically chromosomally unstable tumors such as lung cancer. And what was most striking is when we looked at this data, we really asked the question, how do mutations convert into neoantigens? And then how do structural variants, how do they also convert into neoantigens? And we know neoantigens can be a key driver of immune response. So for mutations, it's a fairly simple linear relationship. More mutations consistently gives more neoantigens, but for structural variants, it was different, more of a flat line there you can see, where despite a high burden of structural variants, there was a downward pressure to suppress the number of exonic SVs, a number of SVs that would make neoantigens. We also saw evidence of immune suppression, a lower T cell score in patients with a high burden of SVs, and then in the final chart there you can see the comparison of somatic structural variants. So clearly they may be immunogenic, they're not subject to self-tolerance, and we benchmark that to germline structural variants that wouldn't be immunogenic, and you can see a big downward pressure, far fewer of the somatic structural variants encoding neoantigens compared to germline SVs, potentially suggesting there is selective pressure against those events. Clinically, we know the importance of exonic fusions here, a classic work from Luke Morris's group, where they showed in an exceptional responder to pembrolizumab, when they mapped T cell activity, in this patient it was linked back to an exonic fusion between DEC and AFF2, so direct evidence of T cell activity against exonic fusions in this context. So back to the summary, we also know that SYN can be a potent activator of the CGAS-STING pathway. So we see cytosolic double-stranded DNA can be recognized by CGAS and then activate canonical and non-canonical forms of STING signaling. We know this can have an anti-tumor effect. It can elicit type 1 interferon responses that can lead to anti-tumor immunity. We know in a chronic context, CGAS-STING can also become pro-metastatic and pro-tumor through promoting an inflammatory environment. And so lastly, focusing on the immunosuppressive side, so we know SYN can promote copy number loss, it can promote genome doubling, and it can help tumors adapt. So in our whole genome sequencing cohort here, we saw indeed patients with a high structural variant burden had poor survival on checkpoint inhibitor treatment, as well as multiple different types of structural variant translocations, head-to-head inversions, tail-to-tail inversions, all associated with poor outcome on checkpoint inhibitor treatment. We know clinical examples show how copy number events can lead to resistance. Here, classic work from Gettinger et al., where they showed a baseline biopsy and then an on-treatment biopsy in an acquired resistant patient. Here, we see copy number loss at the B2M locus as a clear mechanism of acquired resistance in this patient. In our own work, we also see copy number amplifications as a cause of resistance to checkpoint inhibitor therapy. Here, we saw cyclin D1 amplifications. Patients had about half response rate compared to wild-type patients in checkpoint inhibitor therapy, and then that was then confirmed in external cohorts in terms of reduced overall survival on checkpoint inhibitor treatment for cyclin D1 amplified patients. We know, of course, functionally, CDK4 has been shown to destabilize PD-L1, so that may give hint at a mechanism there with cyclin D1 amplified tumors having high levels of CDK4 and then lower ability of stabilized PD-L1 levels. So just to give a summary, we see a very complex set of biomarkers associated with checkpoint inhibitor response. In our pan-cancer meta-analysis, we see clonal tumor mutation burden, CXL9 and CXL13 expression as having strongest effect size. We see a complex role for chromosomal instability. It didn't have a clear, obvious association either way with immunotherapy response. That may reflect the complex biology with both immunostimulatory effects from exonic fusions, as well as CGAS-STING pathway activation, and then, of course, immunosuppressive role of SYN through copy number deletions, impairment of antigen presentation pathway, as well as oncogene amplification that may regulate the anti-tumor immune response. So just to thank all the lab that did this work, as well as all of our collaborators and funders, and thank you very much for your attention.
Thank you. If anyone has any quick questions, please come to the microphone. I understand the app's not working, but we do have the next session about to start, so please get yourselves up to the microphone if you have any questions. Thank you, Kevin. That was great. Okay. All right. Well, thank you, everyone, for coming, and I hope you have a great meeting, and I'll see you around. Thank you. And thank you to all the speakers.
Thank you. Thank you. Great.